Thank you so much, everybody. Good afternoon. Such a warm welcome, and I'm very, and I mean it, thrilled to be here and humbled to be here today in your prestigious Grand Rounds. And thank you so much for organizing this and hosting me here. The topic is new digital technologies era in cardiovascular interventions. I start with my disclosures. This is the outline, a little bit of introduction on which are those digital technologies, the so-called 21st century digital technologies, AI and the role of AI in cardiovascular interventions, simulations, computational simulations, and how they can impact interventions, and then, of course, extended reality and their role, its role in cardiovascular intervention. Finally, a bit of a glimpse, forward thinking on how the cath lab will look in hopefully the near future. We'll start with the introduction of the 21st digital tools. As you can see here, AI, machine learning, deep learning is a big umbrella that encompasses many other entities, computational simulations, and extended reality, virtual reality, augmented reality, or the combination, which is mixed. And we coined this term, the term ACER, to show the unity and to encompass all these three technologies under the same umbrella. Let me start now with how AI can be impactful in the field of cardiovascular interventions. Literally, as you can see here, every 100 years, from the late 1700s, we have a revolution, and it was a steam, electronics, networks. Now, literally, we're on the 5th industrial revolution. God knows what's going to happen 100 years from today, but now we definitely live the dream of AI. And what is AI? AI essentially is nothing that we should be afraid of. AI is a digital brain, like a human brain with in silico. And AI is a computational tool. It's just a toy that it's an aid that helps us perform tasks that are normally characteristic of human intelligence, like pattern recognition, voice recognition, planning, and problem solving, and so on. And I think that more or less we should make ourselves familiar with all these, this is the language, all these terms related to AI, machine learning, essentially advanced statistics, if I can be very plain here, deep learning, an in silico brain with all these neural networks, which are digital, natural language processing, cognitive computing, which is essentially the so-called clinical decision support systems. You feed the system with data, and based on the data, it gives you the recommendation. Computer vision, we feed the system with imaging data now, and it gives us the recommendation. And robotics. So all fall under the same umbrella of AI. And big data here is the key. And I want to emphasize this. Obviously, it's very easy for us to differentiate a dog from a cat. But for the machine, until we train it, that's impossible. You see here, you feed the machine with 1,000 images, accuracy, it's like 50-50 to differentiate a dog from a cat. But you feed the machine with thousands of images, then the accuracy goes almost 100%. It can very efficiently, very nicely, and quickly, like a human brain, say whether this animal is a dog or a cat. And this is very fundamental for us to understand how it works. We have big data, which is what we produce in our daily practice, in our profession. Then we have the aid, the tool, which is AI. It's a system, and then this system processes all this big data to give us an output, to give us a recommendation about a treatment strategy for aortic severe aortic stenosis, to give us a recommendation about the risk to develop a heart attack in the future, to give us a recommendation, to give us a diagnosis about a pathology. So across the board, from diagnosis, prevention, diagnosis, and therapy, this system works very well and is literally based on big data. Without big data, there's no AI that can be reliable. And at the end of the day, all these tools are important because they help us to achieve the goal of precision medicine, precision cardiology in particular here. It's not one size fits all. It's not one technique, one diagnostic pathway, one strategy fits all. But through these big data and machine learning approaches, we can identify groups of patients who deserve better prevention approaches, different diagnostic algorithms, and different treatment strategies. So that's the whole goal, essentially. And these are some applications of how AI in the field of cardiovascular interventions can play an important role, from analysis of automatic in the heartbeat of images, OCT or IVUS, or diagnosis of the extent of calcium burden in OCT images, or the non-invasive assessment of the severity of CAD using non-invasive computational FFR, or even robotics to guide and get through different operations. Now I'm going to move to the role of computational simulations. That's another pillar of the umbrella of digital technologies and how they can play an important role in cardiovascular interventions. And I'm going to spend a little more time on this because we have done some good work on this through our NIH funding. What is simulation? We have different types of simulations. Live simulation, like this one here, this fire drill in this Japanese kindergarten. So these kiddos are simulating essentially what's going to happen if we get, we have a big fire. Virtual simulation, where we have an actual player, like this flight simulator or this World War I wooden horse, before you go to the battle, in a synthetic environment. And then you have computational simulation, in which both the player and the environment are computational, are synthetic. As you can see here, it's all planning of how the aerodynamics of the air can change and help us modify the design of the planes for safety, or same with the car crash simulation and so on. And this comes from Wikipedia. I want to emphasize on the computational simulations today. What is that? It's a simulation that runs on a single computer, but usually in a cluster network of computers, to reproduce the behavior of a system. And the simulation, the computational simulation, uses a computational model to simulate that, to imitate that real system. That's very fundamental. And simulations are abundant in life, all the way from entertainment, automobile industry, name it. You see here all the applications, including, of course, medicine, including, of course, cardiology. But I really want to emphasize, draw your attention on this fundamental slide here, and coin the term digital twins. Digital twin is what? We have a real system where there's like an in vitro experiment, where there's a heart, where there's anything, which we use to perform experiments and extract experimental results and acquire knowledge. And that's very well validated process to acquire and knowledge and learn. Now we have the digital twin, which is a faithful replica of the organ, of the cell, of whatever we want to investigate. And we take it from the body into the computer in a very faithful, anatomically, physiologically way. And we use this model, this computational model, this digital twin, to perform simulations and extract simulation results. And we validate those results against the reality. And once we have a validated in silico replica of the organ, then imagine the amount of the power we have, the ability to perform infinite computational experiments and simulations, as we call them, and improve our knowledge, advance the field, come up with new questions, come up with new answers, which at any point in time can be always answered by going back to experimental studies. So you see how this opens up, this digital twin strategy opens up a totally new field, giving us amazing power in acquiring new knowledge. And I'm going to show you today a couple of hands-on clinical examples of how computational simulations can play a role in coronary interventions, surgical interventions, structural, peripheral, device R&D. I want to highlight this, virtual clinical trials. And I'm not going to focus on this today, but since you're an institute which is heavily loaded on mechanical support, there's lots of AI in this field and simulations in this field as well. I'm going to start with the coronary interventions. The whole concept is that the unmet need is that we need something that is going to help us to personalize the way we do PCIs. Why? To improve outcomes, because we don't have the best of the outcomes, despite this amazing technology of stents and techniques we have. We need something more personalized that takes into account anatomy and physiology. And what other than simulations, computational simulations, to do and follow this personalized approach using biology and physiology to improve our outcomes. That's the most cost-effective and the most and the fastest approach. And that's essentially the premise here. And that's what we did through our NIH funding. We have built up this platform of computational stent simulations where we create in silico digital twins of the heart arteries, and we replicate not only the anatomy, but also the biology, the wall, the material properties, and then we add there realistic stent designs and balloons coming from the industry, and then essentially we have an amazing situation where in a very faithful, anatomically, physiologically, biologically replica, we can test different scenarios, see how the stents work, how the stents interact with each other, with the wall, in a very patient-specific, very patient-relevant environment. A very quick example here, you take angiography, you take OCT or IVUS or CT, whatever, it doesn't matter what's the input, but the output is the in silico digital twin, the replica of the lumen and wall. And not only this, we use imaging to assess and reconstruct in 3D the material distribution. You see here calcium with white, fibrosis, fibrolipid in 3D. And we go one step further and we translate this material distribution into what? Into stiffness. Because at the end of the day, the stent doesn't care whether it's calcium or fibrous in the wall. It cares about how stiff is the material against which I'm expanding. And you see here the correlation. We assign stiffness all the way from very soft to very stiff. It's not 0 or 1, black or white. It's like a spectrum here. And you see the correlation across the digital twin of anatomy and physiology and biology. You see the correlation of imaging to the stiffness. Now what? Let me show you here a very hands-on example on how this can be translated directly to patient care. 60-year-old woman with distal left main by angio and by IVUS. Symptomatic, guidelines dictate clearly that we need to intervene. She denies surgical approaches, and now she comes to us. We stop here and we do the following. We do a planning of the procedure that we're going to do. We create a digital anatomy here, the digital twin, again, lumen, wall. You see here the flow, acceleration across the distal left main stenosis. And then you see here the plaque stiffness, the material distribution across this 3D reconstructed patient-specific digital model. And then we have AI and simulations tell us, for this particular individual, what's the best strategy to prepare this lesion, what's the best strategy to stent this, what's stent size, what's stent length, what's stent technique. And here, the proposal is crossover stent, one stent, no second stent in the circumflex, prepare the lesion with a conventional balloon. That's essentially what is the simulation, and that's the flow, how it would look if we would do this particular recommended technique. You see the flow acceleration is now gone, and the circumflex looks acceptable result, no need for a second stent. So that's what the machine tells us to do for this particular patient. And for those who need a little more, here you go now. That's the recommendation, and that's the reality. So we take the patient back to the table, and we execute to the dot exactly the same plan, as recommended by the AI using simulations. And we do the pre-dilatation, the standing, and the post-dilatation. And then here is the baseline. Here is the post-all simulation, an AI-planned procedure for this particular individual by angiography and also by imaging. You see here the lesion, which is treated with this particular stent, 3.516, with good results. And patient is doing very well, 2 years out now, and she's feeling happy, and she escaped bypass, and hopefully she will be fine for the years to come. Another dimension in how we operate. Now, let's add another layer. Not using intracoronary imaging or invasive studies to plan a procedure, but use CT, non-invasive, which is very popular. We use CT in the same fashion, using simulations and using AI to tell us for this particular individual, what's the lesion preparation, stent length, do we need to protect the side branch or not? We take the information now on the myocardial mass, but the side branch subtends, what angulation on the C-arm, how significant is the lesion. All this relevant information can be acquired from CT and help us non-invasively go to the cath lab in a planned way. But at the end of the day, our job as interventionalists, for those who are interventionalists, is to, and the joy is to do operations, not diagnostic lateral caths, but to do patient relevant procedures that will help patients live longer and have better life, and do PCIs. And we really want to do cases in a planned way to minimize anxiety, to improve efficiency, and at the end of the day, hopefully improve the outcomes. Same here, another example, using CT. We have now the ability, and photon counting CT is coming in the horizon right now, to very nicely 3D reconstruct the calcified lesions and devise the right lesion preparation strategy and the right stent plan for this particular individual based on this particular distribution of calcium in these coronary arteries. Now, I switch gears to the planning of surgical interventions, because that's also very important. And there's some data from this fast-track study which showed that the investigators compared two arms. One arm was the conventional heart team deciding about the bypass, and the other arm was essentially no cath, just CT angiography, and then based on the CT only, without cath, making the planning for the bypass. And the study showed that it's feasible to operate, do a bypass without invasive angiography, but just with CT, and it's also safe up to 30 days. That's what the study showed, that graft patency up to 30 days was safe whether you go angio-guided or CT-guided bypass surgery. But now we want to push the envelope to one step further and use non-invasive simulations, computer simulations, to plan and devise the surgical plan. And I'm going to show you this, how it works. We use anatomy. We create now another digital twin, which is called aorta with a big branch in the coronaries. And we computationally, virtually bypass. Believe me, that's very safe, zero risk there. And then you assess the flow in the computationally implanted graft and in the native arteries, which is a digital replica of the real arteries. And you can predict whether a lima to a 50% LAD is going to stay open or not. And that's very important, because if it's not going to stay open based on the prediction, maybe don't do it. That's better. And this is a very fundamental, easy for you to understand, nothing special, but it's important to realize that you see here the machine has the ability, the simulation has the ability to replicate a physiological phenomenon, which is what? This is the lemma, that's the proximal AD, that's the distal AD, and during diastole, you have retrograde flow into the LAD because this LAD here is so significantly diseased. Again, common knowledge, nothing new for you, but imagine that the machine now replicates a physiological phenomenon which attests to its accuracy. And now you can use the machine and play and make this stenosis less severe, and you'll be surprised positively to see that if you make it less severe, there's no retrograde flow, and the flow in the LAD is actually stronger sometimes than the lemma, and they might have retrograde flow to the lemma. In that case, probably don't do the lemma. And is there any surgeon who wouldn't like to have this information up front before we go to the operation? So the whole idea is to use computation simulations, patient-specific and relevant simulations, to plan the surgical the surgical operations, the cabbage, in terms of the number and the type of grafts. Because if I'm going to graft a lemma to a not very significantly stenosed LAD, maybe avoid the arterial graft and maybe use a venous graft if you don't want to use any graft at all. And hopefully this way we can improve graft patency, but also we can improve clinical outcomes. So that's a very exciting field that is coming to the horizon. I'm gonna move now to the structural operations planning using simulations of structural operations. We can do the same concept of digital twins for TAVRs, for TER, and then of course for appendage occlusions. I'll show you some examples here how simulations, computation simulations can help us plan TAVRs. That's a 23 SAPIEN valve. In a very specific way, we replicate the whole anatomy, the aortic valve, the aorta, and see how the valve, the SAPIEN 3 or 26 or whatever valve you want, it's X-ray free, it's risk free, it's very forgiving environment, but very, very important information that helps us with planning. And then you see the same anatomy with 26 Evolut valve. And now we can see how one or the other valve interacts with the coronaries. For example, here, this particular Edwards valve, the S3 doesn't interfere at all with the left coronary, keeps my right coronary also open, and no PVL, no paravalvular leak, aortic view, or ventricular view. Isn't this fascinating to be able to see like echo, but from any kind of view by creating digital twins, you have this infinite capability to get a sense of what's going on and go to your procedure in a very planned way. But if you, in this particular case, you use a 26 self-expanding, you might end up with paravalvular leak because you have this hole here, as you can see. That's a very good consideration to plan and tailor what's the right device type and device size for this particular anatomy. And of course, the risk for annual perforation, the so-called annular stretch. With this particular valve, the risk here is on the side where some calcium, the area of calcium in the LVOT around the annulus, and that's something that you need to consider as well. Maybe this can help you plan accordingly how you expand the valve, how aggressively you postdilate the valve, how you size the valve, and so on. Same with the mitral valve, edge-to-edge repair. Again, we can replicate the left atrium, the mitral valve, and plan the procedure, see how one clip, two clips can behave, and give you important information before you go to the actual operation. By failing to prepare, you're preparing to fail. Same with the appendage occlusions, as shown here in this video. We can, okay, this doesn't play, but same way we can essentially use the particular digital twin of the particular appendage and decide about the type of the appendage occlusion device and the size in terms of like the possible risk for leak, para-device leak, and so on. So very, very important. And now I'm going to go to some research component here, how simulations can help us with the so-called device R&D. We discussed about the impact of simulations on coronary surgical interventions, on structural interventions. Lots of things also happen in the peripheral, but I'm going to focus on how simulations can help us with device R&D. This comes from the FDA. This shows illustrates the so-called total product life cycle. From the inception, the R&D, to regulatory approval, and to post-market monitoring. And simulations and AI can play an important role across all the stages of development of a product, across the entire total product life cycle. FDA recommendations here on how animals, bench, and simulations perform when it comes to device testing. And you see here, red is poor performance, green is good performance. And I would say that simulations get quite a few greens here. And I would like to draw your attention on which are those greens. Our ability to predict performance of the device beyond the indication for use. Because we can dial up, dial down the device in a very forgiving environment, in a very cost and time effective way, and see how the device responds. To do this in animals is not easy. It takes time, it takes money. Adaptable for patient specificity. We had this discussion with Dr. Yiannis this morning. There's no way we can replicate the complexity of left main calcification in any animal model. But we can do this computationally. We can extract from the body this particular calcified left main, the faithful anatomically and physiological replica, and use it as we feel to assess the performance of our device in this replica. And of course, cost and time, which is not negligible factors, which is not the case for animals, because animals, experimental tests take time and money. So you see that devices can be treated nicely with simulations when it comes to assessing their performance. And I'm showing here a humble example of how simulations were used in this particular case by our group to test this stent, which came into the market a couple of years ago. And they had several prototypes and didn't know which one to use. And what we did is that we took patient-specific digital twins, left mains, and we used computationally, and we assessed computationally the performance of all these prototypes. So on each replica, on each digital twin as shown here, you see the performance of all the prototypes, head-to-head comparison. And that's patient-specific. And there's no animal model that can replicate this complexity. And we found out that this particular prototype, this particular design, was better than the other prototypes, and that's particularly the one that is now out commercially available, and that's the one that got FDA clearance. But I'm going to be a little more forward-thinking here, and I'm going to go to the virtual clinical trials. And I believe this is very exciting times. Don't get me wrong, we live in an era of evidence-based medicine, and the pinnacle of evidence-based medicine is called randomized clinical trials. That's the only way right now to acquire important new knowledge without bias. Is that true? There's bias there. Where's the bias? On the population we study. Because the majority of the studies, of the clinical trials, not only in cardiology, in medicine in general, have been conducted historically on middle-aged, white males. And guess what? We forgot about half of our population, which is women. I'm not even going to ethnicities, Indians, Greeks, Puerto Ricans, and so on. So, massive underrepresentation. Also, increased dropout rates. This is statistics from a few years back that show that nearly 20% of the trials, they prematurely shut down or they're delayed significantly, sometimes 2 times 3, as long from the plant end. And not even mention the increasing costs and resources. So the idea, and this also comes from the FDA, FDA right now is pushing the envelope with the so-called in silico, virtual clinical trials. And the whole concept is not to abandon randomized clinical trials, which is the pinnacle of evidence, no discussion about this, but to help them become faster, cheaper, and more relevant. And the concept is, as shown here, we have devices, we have techniques, name it, and we don't test them in actual patients up front, but we test them in a diverse patient population, in a diverse population of digital twins. We have a device, 3 total artificial heart designs, get 5,000 diverse heart anatomies, and test the performance of these devices in terms of like flow, name it, whatever is the metric there. So essentially, we use simulation endpoints, surrogates, which are highly predictive of clinical outcomes. I'll give you an example with the stents. We have 5 stents, and we want to know which one is the best. There's no clinical trial that kind of says this. You know why? It's very expensive, and nobody wants to pay this. However, if we run this in a very time and cost-effective way, test those 5 stents in 1 million coronary anatomies, which we can acquire very easily from registries and from cath labs across the globe in a very representative, very diverse way, and get a signal of those 5 stents, which are the 2 best in terms of like, what's the metric here? Expansion, which we know very well that stent expansion is directly linked to bad outcomes. So the best 2 stents out of those 5, in terms of like stent expansion, can then enter an actual clinical trial with real patients, with actual clinical outcomes, MACE, with a follow-up of 1-2 years. But guess what? Much more powered because it's facilitated, it's guided by the signal we got from the in silico trial, and most likely faster and less expensive because we don't require that many patients now to randomize. And that's how we can push the envelope and advance the scientific knowledge in a very time and cost-effective way. We talk essentially about the virtual clinical trial regulatory pathway that through in silico trials helps the FDA, industry, academia, NIH to push the envelope, advance knowledge in a very time and cost-effective way. I think I used the word time and cost-effective way at least 10 times today, and trust me, it's not random. I just want to highlight that all these tools, AI and simulations, are not here to replace us, but they're here as aids to help us do faster and cheaper and better job. And then I'm gonna close with the role of simulation of extended reality in cardiovascular interventions. Extended reality is a big umbrella. Virtual reality means when I'm immersed totally in the virtual environment, I have no understanding of my surroundings. Augmented reality is when I'm not totally immersed, but I see what's going around. I don't hit on the wall. And then mixed reality is a combination of both. And I show here some very plain examples of how extended reality can help us with current interventions. This is a big room, virtual room, where we sit like a red blood cell with a camera in the middle of the bloodstream, watching around the stent and the flow. I think it's important, cognitive experience, to see what's going on there. That's the holographic display of your procedure. This EP, this structural operator here has in front of him the whole anatomy to help him do a better job, versus translating 2D shadowgrams into what the brain is used to function, which is called 3D, three-dimensional. Peripheral interventions. This person here is sitting like it's a real room. It's called cave, and you just walk around and see around you the stent struts, which are 80 microns in thickness, and they're in front of you. We talk about using extended reality for our trainees to move their training to the next level. Seeing is believing. Help them learn greater, faster, and better. Of course, we like textbooks and YouTube videos, but in 2024 and the years to come, we need something more to accelerate education and training. Help our trainees, as I said, learn greater, faster, and better. In our cath lab, our fellows now, before they go to the cath lab and learn by trial and error on our patients, they pass through this. They wear the headsets, X-ray-free environment, contrast-free environment, spend an hour, 2 hours, learn experientially. See how when you move the eye, the projection of the coronaries changes. And when you familiarize yourself with this, go to the cath lab for your rotation. Different level of training. For more advanced fellows, our interventional fellows, how it looks like when you do provisional, means 1 stent, not 2 stents. How it looks on the side branch. What is proximal optimization technique? How the kissing balloon behaves, all those things. You wear the headsets, this is a video right now, but you imagine having the headsets and seeing this from the inside, like a red blood cell with a camera. Important, unforgettable, experiential learning. A more complex technique, decay clot. I don't want to go into details here, but we have 2 stents here. We put the stent, the first stent, now we're waiting for the second stent. Where are we gonna put the second stent? How it interacts with the first stent? How it looks at the carina? All those things are important information that's gonna help our trainees learn greater, faster, and better. And this come all from simulations and AI and extended reality. And of course, don't forget ACER, AI, simulations, extended reality, they're together. They are different aspects of the same kind of like entity, if you want. It's called digital technologies. And they're so well interrelated. Simulations feed AI and vice versa, extended reality and vice versa. And then finally, without being provocative, I'm gonna close with the cath lab of the future, some thoughts. We need more than what we have to achieve better outcomes for our patients, to have better and longer life. And to achieve this, we need in real time, and I highlight this, not offline, in real time, lumen segmentation, correlation with angiography, 3D anatomy, not 2D, because our brain is not used. It's a torture when you ask the human brain to operate on 2D. Our brain is not used fundamentally to operate on 2D. We do that, but it's a simple extrapolation of 3D to 2D, and that's mentally exhausting. But we can understand things better in 3D because we have advanced cognitive skills. FFR, stiffness, material, and I need to know the procedure, the result, how the stent is going to look like, how the flow is going to look like before I do it. The simulation, essentially, of the procedure that I'm going to do, and the recommendation of what procedure I'm going to do in this particular patient. And all in real time. Do I ask for a lot? Maybe. But I believe we're about to go to Mars. This is nothing, and we deserve this. And that's why I believe it's hopefully near future, not far future. And the concept is use any kind of imaging, whether it's invasive or non-invasive, as it becomes more popular nowadays, and then use AI to give you the diagnosis. Doesn't replace the doctor, but it's the mega brain, it's the expert of the world, all consolidated in one mega brain, and democratizes the knowledge, because I might be an expert, but somebody else in Greece right now is not that much expert. Why we deprive this individual from the ability to have access to the latest and the best of the knowledge? That's what AI does. Democratizes the knowledge, makes everybody an expert. And feel free to override AI and any recommendation at any time based on your experience, your beliefs, or whatever. It's a tool that gives us a diagnosis in a very fast and very accurate, precise way about structural coronary peripheral issue. And then we engage computer vision to recommend the treatment strategy for this particular structural coronary peripheral problem. And then we have the robot to deliver this plan. And hopefully, this way you can achieve consistency, better guidance to the operator, more satisfaction to the physician, to the staff, to the patient, better workflow, better economics, and hopefully the pinnacle of what we do, that's how we're judged, is improved clinical outcomes. Again, I don't believe we're far from this. And it comes with limitations and the biases. And don't get me wrong, everything has limitations. Is it diverse, this recommendation? Again, big data. Big data, the bigger the data, the more diverse the data, the more diverse the recommendation. If you train the machine into this population here, we're going to have an excellent recommendation, but for your phenotype, not for others. It's very expensive, of course, not widely available. But the iPhone was very expensive. Yeah, maybe it still is, but it's getting cheaper and cheaper with the technology. That's the evolution, essentially. Legal, somebody dies. Is the machine or the doctor liable? Who's going to go to the court? FDA and regulations are needed. There's no tactile with simulations. Of course, there's no tactile. It's all computational. So there's limitations. And some of those are literally very practically impossible to address, like the tactile. But most of those limitations and biases can be addressed with time and with a very nicely developed framework. And I will summarize with this graphical summary of the digital era of cardiovascular interventions, where we have AI tools, computation simulations, extended reality tools, and they help us with planning of procedures, intra-procedural visualization, with device R&D, with virtual clinical trials to accelerate knowledge in a time and cost-effective way, and of course, with education and training, which is very, very important as well. So take-home messages, these new digital technologies, AI, simulations, extended reality are feasible. That's good news. AI can help us with the diagnosis and treatment of cardiovascular disease. And again, it's heavily based on big data, which we have abundant, by the way, but we have them stored sitting there. Simulations, computation simulations can help us with the planning of our procedures, extend reality with planning of procedures to understand better what's going on in the particular patients you treat, and of course, education and training. And finally, AI, simulations and extend reality have the potential to revolutionize, to change the practice, research, and training in cardiovascular interventions in the years to come. I would like to a big thank you to my group, our engineers, programmers, visualization AI experts, MDs, and vascular biologists who work very consistently on all these concepts all those years. A big thank you, obviously, to the funding resources from federal, industry, and philanthropy resources. And I would like to thank you for your attention. And once again, thank you so much for having me today here in this prestigious event. Thank you.